Hello everyone, this is Dr. Sam and this video is about fetal brain ultrasound reporting. You will learn how to write ultrasound reports regarding fetal brain pathologies. The reports will mainly include the clinical indication, gestational age, findings and impression. The reports are related to fetal brain. Keep in mind that these examples are not of a complete obstetric ultrasound report. We mainly focus on brain pathologies. This first example is of a normal fetal brain, clinical indication, routine evaluation of fetal anatomy. Gestational age is 22 weeks. These are the findings. You can start with the fetal biometry, which includes biparietal diameter and head circumference. The BPD is 54 millimeters, which is consistent with the gestational age. Head circumference is 200 millimeters, correlating well with the gestational age. Then you can write about the cerebellum. The transverse cerebellar diameter is within normal limits for gestational age. Then you can write about cisterna magna, measured at 4 millimeters in this example, which is within normal range. Nuchal fold is normal in thickness. Then you can write about the lateral ventricles. The width of the atria of the lateral ventricles is normal, with no evidence of ventriculomegaly. Choroid plexus appears normal bilaterally, with no cysts noted. Midline forks clearly visualized with no deviation, suggesting no shift in intracranial contents. Cavum septum pellucidum well visualized, indicating normal midline structures. Corpus callosum. The corpus callosum is intact and visible throughout its length. Cerebral hemispheres, no abnormalities detected. The gyral pattern is appropriate for gestational age. Cerebral ventricles, normal in size and configuration. Third and fourth ventricles, normal in appearance. Cranium, no evidence of craniosynostosis or other skull deformities. Doppler studies. The middle cerebral artery Doppler study shows normal resistance patterns with no signs of fetal anemia. And here is the impression. Normal intracranial anatomy with biometry consistent with the gestational age of 22 weeks. No evidence of intracranial abnormalities is noted at the time of this examination. Continue routine prenatal care. Follow-up ultrasound may be performed as clinically indicated or per standard obstetrical care guidelines. Here is a case of mild ventriculomegaly. Clinical indication, follow-up for previous finding of ventricular prominence. Gestational age 24 weeks. These are the findings. BPD 56 millimeters within normal limits for gestational age. HC is 210 millimeters correlating with gestational age. Cerebellum is normal in appearance. Cisterna magna measured at 4 millimeters within normal limits. The nuchal fold is also within normal range. These are the findings of the ventricles. Right lateral ventricle measured at 11.5 millimeters. Left lateral ventricle is measured at 10.2 millimeters. These measurements are noted to be mildly dilated. Ventriculomegaly is defined as an atrial diameter of the lateral ventricles measuring greater than 10 millimeters. The cavum septum pellucidum is present and normal in appearance. Corpus callosum is visible and intact throughout its length. The cerebral hemispheres have no structural abnormalities. The third and fourth ventricles appear normal in size and configuration. The MCA Doppler is also normal. This is the impression. Mild bilateral ventriculomegaly is noted, with the atrial diameter of both lateral ventricles slightly above the normal range. There are no additional findings suggestive of an underlying abnormality on this examination. This is a continuation of the impression. Consideration for a detailed fetal anomaly scan to exclude associated anomalies. Potential referral to a fetal medicine specialist for further assessment and counseling. Serial ultrasound examinations are recommended to monitor ventricular size and assess for stability or progression. Consultation with a pediatric neurologist may be beneficial for postnatal follow-up and intervention planning. Now we have a report for moderate ventriculomegaly. Clinical indication: progressive ventricular dilation noted on previous scan. Gestational age 24 weeks. These are the findings. The BPD and HC are normal. The cerebellum has normal morphology. The cisterna magna is within normal limits, and the nuchal fold is normal. The right lateral ventricle is measured at 14 millimeters, and the left lateral ventricle is measured at 15 millimeters. So this suggests moderate ventriculomegaly. Choroid plexus, midline falx, cavum septum pellucidum, and corpus callosum are all normal. The cerebral hemispheres, the third and fourth ventricles, are normal. The Doppler studies of fetal cerebral vessels are also normal. This is the impression. Moderate ventriculomegaly is present, with both lateral ventricles measuring above the normal threshold. No additional abnormalities are noted. The findings may indicate an isolated ventriculomegaly. However, further evaluation is recommended to rule out associated anomalies or a potential underlying cause. A detailed fetal anomaly scan should be considered to further evaluate the fetus or any other structural abnormalities. Referral to a fetal medicine specialist for comprehensive evaluation and counseling is strongly advised. Amniocentesis may be offered for chromosomal analysis and to rule out infectious etiologies. Serial ultrasounds should be scheduled for close monitoring of ventricular size and fetal growth. Pre-delivery consultation with a neonatologist and a pediatric neurosurgeon is recommended to discuss prognosis and postnatal management options. MRI could be considered for additional detailed neuroanatomic assessment. Now we have a case of severe ventriculomegaly. Clinical indication is evaluation of ventricular dilation noted on an anomaly scan. Gestational age 24 weeks. Here are the findings. Biparietal diameter is 59 millimeters, which is on the lower limit for the gestational age. Head circumference is 218 millimeters, slightly below the 50th percentile for gestational age. The cerebellum is normal in size. However, there is effacement of the cisterna magna. Nuchal fold thickness is within normal range for gestational age. The right lateral ventricle atrium measures 21 millimeters. The left lateral ventricle measures 22 millimeters. It indicates severe ventriculomegaly. The ventricular atrial width is significantly enlarged, consistent with severe ventriculomegaly, defined as an atrial diameter greater than 15 millimeters. Choroid plexus appears compressed and displaced due to the enlarged ventricles. Midline forks in place but thinned, likely secondary to the ventricular enlargement. Cavum septum pellucidum not well visualized, possibly due to distortion from ventriculomegaly. Corpus callosum not clearly visualized in its entirety, suggesting possible agenesis or compression. Cerebral hemispheres, there is evidence of reduced periventricular white matter. Cerebral ventricles, third and fourth ventricles are difficult to assess but appear dilated. Here is the impression. Severe bilateral ventriculomegaly with associated secondary findings suggestive of pressure effects on adjacent cerebral structures. The dilation of the ventricles is concerning for a significant neurodevelopmental impact, consideration for a comprehensive fetal anomaly scan, and fetal MRI for a detailed assessment of the central nervous system and to evaluate for other structural anomalies. Genetic counseling and consideration of chromosomal microarray analysis or karyotyping may be beneficial. Consultation with a pediatric neurologist and neurosurgeon should be arranged to discuss the prognosis and potential interventions, including the possibility of in utero or postnatal surgical management. Further assessments such as infection screening and possible amniocentesis could be considered based on the clinical correlation. Parents should be counseled about the potential for significant neurodevelopmental impairment and long-term management considerations. Here we have a report for dangling choroid plexus. Clinical indication: concerns raised during routine prenatal screening. Gestational age 26 weeks. These are the findings. The cerebral hemispheres, cerebellum, and other brain structures appear within normal limits for gestational age. There is evidence of ventriculomegaly, with the lateral ventricles measuring approximately 15 millimeters, exceeding the normal range for this gestational age. The choroid plexus is observed dangling into the lateral ventricles, more pronounced on the left side, which is atypical and suggests a dangling choroid plexus cyst. No other abnormalities such as hemorrhage or significant deformities are observed in the surrounding brain tissue. This is the impression. The sonographic findings are indicative of ventriculomegaly with a dangling choroid plexus. While the dangling choroid plexus itself is usually a benign finding, the associated ventriculomegaly may have clinical significance and requires further evaluation. The etiology of ventriculomegaly in this case remains unclear and warrants additional diagnostic investigation. Follow-up ultrasound in 2 weeks to reassess the ventricular size and morphology of the choroid plexus. Consideration of fetal MRI for a more detailed assessment of brain anatomy and to investigate potential underlying causes of ventriculomegaly. This is a report for aqueductal stenosis. Clinical indication: evaluation of previously detected ventriculomegaly on an anatomy scan. Gestational age 22 weeks. These are the findings. The BPD is normal. but the HC is 210 millimeters at the upper limit for gestational age. The cerebellum, cisterna magna and nupal fold are normal. Both the lateral ventricles are dilated. The right lateral ventricle atrium measures 15 millimeters and the left lateral ventricle atrium measures 16 millimeters. The third ventricle is dilated, measuring 10 millimeters in width, indicative of ventriculomegaly. The fourth ventricle is normal in size and morphology. The corpus callosum is normal. The cerebral hemispheres and the Doppler studies are normal. This is the impression. The ultrasound findings demonstrate dilated lateral ventricles and third ventricle with suspected aqueductal stenosis. This is indicative of obstructive hydrocephalus. The severity of ventricular dilation warrants close follow-up and potential intervention. Referral to maternal fetal medicine for consultation and further management. A fetal MRI is recommended for a more detailed anatomical assessment and confirmation of ultrasound findings. Genetic counseling and testing may be warranted as ventriculomegaly can be associated with chromosomal abnormalities and genetic syndromes. Consideration for prenatal consultation with pediatric neurosurgery for counseling on postnatal management, which may include surgical intervention. Serial ultrasounds should be performed every 2 to 4 weeks to monitor for progression of ventricular dilation and assess for any additional anomalies. Parental counseling regarding the potential for neurological impairment and long-term outcomes should be initiated. Now we have a report for Hydranencephaly, gestational age 28 weeks. These are the findings. The BPD is measured at 70 millimeters, which is within the expected range for gestational age. The head circumference is measured at 250 millimeters, slightly above the 95th percentile for gestational age. The cerebellum, cisterna magna, and cranial bones are normal. Ventricular system. The lateral ventricles are not clearly visualized. The third and fourth ventricles are also not apparent. Cerebral tissue. There is a near complete absence of the cerebral hemispheres. Both hemispheres are replaced by a large anechoic fluid-filled space consistent with cerebrospinal fluid. Falx cerebri. Only remnants of the falx cerebri are noted. Thalami, partially visualized but appear to be floating within the fluid-filled space. Basal ganglia, not well visualized due to the extensive fluid replacement. Skull shape. The cranial vault has a boxer's glove appearance, which is typical in cases of severe intracranial destruction. This is the impression. The sonographic appearance is highly suggestive of Hydranencephaly. There is a near complete absence of the cerebral tissue with preservation of the skull shape and portions of the base of the brain. This condition is characterized by the replacement of the cerebral hemispheres with cerebrospinal fluid. Immediate referral to maternal fetal medicine specialist for comprehensive evaluation and discussion of prognosis. Consideration for a detailed fetal MRI to confirm the ultrasound findings and to assess the remaining brain structures more clearly. Genetic counseling should be provided to discuss the likelihood of genetic or environmental causes and to prepare for potential decisions regarding the continuation of the pregnancy and management options. Regular monitoring and follow-up with serial ultrasounds are advised to assess the fetal head circumference and any potential progression of the condition. Parental counseling regarding the poor prognosis associated with hydranencephaly, including the potential for severe neurological impairment or non-viability, is advised. This is a report for severe hydrocephalus, gestational age 30 weeks. These are the findings. The BPD is 85 millimeters, much greater than 95th percentile for gestational age. The head circumference is 320 millimeters, much greater than 95th percentile for gestational age. It indicates that the values are increased. Lateral ventricles, severely dilated with an atrial width of right lateral ventricle 25 millimeters and left lateral ventricle 24 millimeters. Third ventricle not separately visualized due to marked dilation of the lateral ventricles. Fourth ventricle appears compressed and is not clearly delineated. Cerebral tissue. The cortical mantle is significantly thin, suggesting a severe degree of hydrocephalus. Cisterna magna obliterated by the dilated ventricles. Cerebellum. Appearances are compromised due to significant distortion from the dilated ventricles, but no intrinsic abnormality visualized. Midline shift, none observed, likely due to symmetric enlargement of the ventricles. Skull bones, thinned but intact. Spine, no abnormalities detected. Face, normal profile and structure in the available views. This is the impression. The ultrasound findings are suggestive of severe fetal hydrocephalus, characterized by significant dilation of the lateral ventricles and a thin cortical mantle. The degree of ventriculomegaly is concerning and implies a substantial impact on fetal brain structure and development. Referral to maternal fetal medicine for detailed assessment and counseling regarding prognosis is advised. Consideration of fetal MRI to better delineate the brain anatomy and assess for underlying causes such as aqueductal stenosis or other obstructive processes. Consultation with a pediatric neurosurgeon to discuss the potential for postnatal intervention is recommended. Genetic counseling to address potential hereditary aspects and discuss the implications for future pregnancies is warranted. Discussion of the implications for delivery, including the possibility of the need for a cesarean section due to increased head circumference, is recommended. This is a case of Porencephaly. Clinical indications: abnormal previous ultrasound with suspicion of intracranial cystic structures. The patient reports a family history of genetic abnormalities. Gestational age 26 weeks. These are the findings. BPD and HC are normal. Lateral ventricles dilated bilaterally, right measuring 12 millimeters and left measuring 13 millimeters. Cerebral parenchyma. Multiple cystic areas identified within both cerebral hemispheres. The largest cyst measures approximately 20 into 15 millimeters in the right hemisphere and 22 into 18 millimeters in the left hemisphere. These cysts appear to be communicating with the ventricular system consistent with porencephalic cyst. Cerebellum is normal in size but with potential mass effect noted from the supratentorial cyst. Cisterna magna is normal. Cerebral hemispheres, preservation of surrounding parenchyma, but with the noted cysts and areas of thinning adjacent to the cyst. Midline structures, no significant deviation. The corpus callosum is visualized and appears intact. Skull bones are normal in configuration. Doppler studies are also normal. This is the impression. The presence of multiple cystic lesions within both cerebral hemispheres, consistent with porencephalic cysts, likely reflects a significant insult to the brain, which may have been ischemic or hemorrhagic in nature. The findings warrant further investigation and correlation with clinical history and possibly genetic testing. This is a report for closed lip schizencephaly. Clinical indications: abnormal findings noted on routine second trimester anatomical survey, suggesting possible cerebral malformation. No known family history of congenital anomalies. Gestational age 28 weeks. These are the findings. The BPT and HC are normal. The lateral ventricles bilaterally are normal. The third and fourth ventricles are also normal. Cerebral parenchyma. A region of abnormally appearing brain parenchyma is noted in the left cerebral hemisphere. The cerebral cortex appears thickened and shows abnormal sulcation, suggestive of a closed lip form of schizencephaly. No significant separation of the abnormally formed cortical tissue is observed, consistent with the closed lip variant. The cerebellum is normal. The cisterna magna and the midline structures are also normal. The skull bones and the spine are also normal. This is the impression. Findings suggestive of closed lip schizencephaly characterized by abnormal cortical formation and sulcation in the left cerebral hemisphere. No open clefts are noted, which is consistent with the closed lip variant. There is no evidence of hydrocephalus or midline shift at this time. You can also write these statements in a section called Recommendations. Referral to a maternal fetal medicine specialist for further evaluation, counseling and management. Consideration of fetal MRI for more detailed brain imaging and confirmation of the ultrasound findings. Genetic counseling to discuss the possibility of associated genetic syndromes and recurrence risks. Consultation with pediatric neurology for anticipatory guidance and early intervention planning. Serial ultrasounds to assess for any progression or development of hydrocephalus. Discussion with the parents about potential neurodevelopmental outcomes and supportive services. Now we have a report of open lip schizencephaly. Clinical indication: follow-up for previously noted abnormal cerebral anatomy on routine anomaly scan. The patient has a non-significant family history. Gestational age 27 weeks. These are the findings. The BPD and HC are normal. Lateral ventricles, presence of bilateral clefts extending from the lateral ventricles to the cerebral cortex. Third and fourth ventricles are normal in appearance. Cerebral parenchyma, bilateral cerebral clefts noted with direct communication between the lateral ventricles and the subarachnoid space. These findings are consistent with the open lip form of Schizencephaly. The clefts are lined by dysplastic gray matter, confirming the diagnosis of open lip Schizencephaly. The cerebellum and cisterna magna are normal. Midline structures. The cavum septum pellucidum is absent, which can be associated with this condition. The skull bones appear intact without craniosynostosis. This is the impression. The ultrasound findings are indicative of open lip Schizencephaly with bilateral clefts extending from the lateral ventricles to the cerebral cortex. The clefts are lined with dysplastic neuronal tissue and communicate with the subarachnoid space. The absence of the cavum septum pellucidum is a commonly associated finding. Recommendations: referral to a maternal fetal medicine specialist for comprehensive evaluation and multidisciplinary management. Fetal MRI for a detailed assessment of the cerebral anatomy and confirmation of the extent of the clefts. Genetic and infectious disease consultation to determine potential etiology. Consultation with pediatric neurology for postnatal care and intervention strategies. Regular monitoring of fetal growth and amniotic fluid volume. Now we have a case of arachnoid cyst. Clinical indications. Routine prenatal screening indicated possible intracranial cystic formation. No known family history of congenital anomalies. Gestational age 24 weeks. Here are the findings. The BPD and HC are normal. Lateral ventricles within normal limits for gestational age. The third and fourth ventricles are also normal. Cerebral parenchyma. There is a well-defined anechoic cystic structure measuring approximately 30 into 25 millimeters located in the left middle cranial fossa, which is suggestive of an arachnoid cyst. No evidence of mass effect or midline shift. The cerebral parenchyma surrounding the cyst appears normal without signs of compression. The cerebellum, cisterna magna, midline structures and skull bones are normal. Here is the impression. The presence of a unilateral arachnoid cyst in the left middle cranial fossa without associated ventriculomegaly or midline shift. The cyst is not causing apparent mass effect on the surrounding cerebral structures. These are the recommendations. Follow up with a detailed fetal MRI for further characterization of the arachnoid cyst and assessment for any subtle structural anomalies not appreciated on ultrasound. Referral to a maternal fetal medicine specialist for ongoing evaluation and management. Regular follow-up ultrasounds to monitor for potential growth of the cyst for development of hydrocephalus. Postnatal imaging and consultation with pediatric neurology and neurosurgery to determine the need for intervention. Genetic counseling may be offered to discuss the low risk of associated chromosomal anomalies and provide reassurance. This is a report for choroid plexus cyst. Clinical information, routine anatomic survey, no family history of genetic disorders, normal first trimester screening results, gestational age 18 weeks and 4 days. These are the findings. The BPD, HC, femur length and abdominal circumference are all normal. The head and neck are normal. In the brain, a single choroid plexus cyst is identified in the left ventricle, measuring approximately 10 millimeters in size. No other brain anomalies are noted. The spine is intact with no evidence of spina bifida or other spinal abnormalities. The face is also normal. The heart, lungs, abdomen and internal organs are all normal. The extremities and amniotic fluid volume are normal as well. This is the impression. A solitary choroid plexus cyst was identified within the left ventricle of the fetal brain. These cysts are often benign and can resolve spontaneously. There are no other abnormal findings, and no additional markers for chromosomal anomalies are noted at this time. Given the isolated finding of a choroid plexus cyst, a follow-up ultrasound is recommended in the third trimester to reassess the cyst, typically around 28 to 32 weeks gestational age. The presence of the cyst should be communicated to the patient's obstetrician for correlation with other clinical findings and lab work. Consider if any risk factors or additional findings suggest a chromosomal abnormality. Genetic counseling may be offered to discuss the significance of choroid plexus cysts in relation to chromosomal anomalies, typically if the other markers are present or if the patient has concerns. You can also write a note in some cases. For this example, this is the note. The isolated presence of a choroid plexus cyst, especially when no other abnormalities are noted, is usually a benign finding. However, when associated with other ultrasound markers, the significance may differ. Clinical correlation and a multidisciplinary approach are recommended for optimal patient care. Now we have a report for Alobar Holoprosencephaly. Clinical indication: routine 20-week anatomical survey indicated abnormal cranial shape, high-risk pregnancy due to advanced maternal age. The patient opted out of first trimester screening. These are the findings: BPD below 5th percentile for gestational age, head circumference significantly reduced below 5th percentile for gestational age. Cranial anatomy: the fetal cranium shows a monoventricular cavity consistent with Alobar Holoprosencephaly. There is fusion of the thalami and absence of the midline structures, including cavum septum pellucidum and corpus callosum. The interhemispheric fissure is not visualized. Falx cerebri is absent. Craniofacial anomalies are present, including hypotaylorism and a proboscis above the eyes, indicating a severe midline defect. Cerebral parenchyma: severely abnormal with no clear distinction between cerebral lobes, absent olfactory tracts and bulbs. Cerebellum and posterior fossa: cerebellum appears hypoplastic. Posterior fossa is abnormally small with a crowded appearance. Extracranial anatomy: the spine and limb anatomy appears within normal limits. Cardiac anatomy reveals complex heart anomalies, often associated with holoprosencephaly spectrum disorders. Here is the impression: Alobar holoprosencephaly characterized by a monoventricular cavity, absence of midline cerebral structures, craniofacial anomalies, and associated cardiac defects. This is consistent with a poor prognosis. Recommendations: immediate referral to a maternal fetal medicine specialist for further assessment and counseling. Fetal MRI for confirmation of the diagnosis and detailed assessment of associated anomalies. Genetic counseling counseling to discuss the potential causes of holoprosencephaly, including chromosomal abnormalities and genetic syndromes, detailed echocardiogram to further evaluate the cardiac anomalies, consideration of karyotyping or chromosomal microarray analysis to identify any underlying genetic etiology. Discussion with the parents regarding the prognosis, which is generally poor for Alobar Holoprosencephaly, and exploration of options including continuation of pregnancy. Sonographer's notes: the findings are consistent with a severe form of holoprosencephaly, suggesting a significant developmental anomaly. The family was informed of the findings during a post-ultrasound counseling session, and a follow-up appointment with maternal fetal medicine is scheduled for early next week. Now we have a case of Semilobar Holoprosencephaly. Clinical history: routine screening ultrasound at 20 weeks suggested abnormal brain morphology. Referred for detailed neurosonogram. No known family history of congenital anomalies or genetic disorders. Gestational age 24 weeks. These are the findings. BPD measures below expected range for gestational age. HC reduced below the 10th percentile for gestational age. Partial separation of cerebral hemispheres is noted, predominantly in the posterior aspect of the brain. There is partial formation of the interhemispheric fissure, but the separation is incomplete anteriorly. The thalami are partially fused. Absence of the septum pellucidum. The corpus callosum is not well visualized, suggesting agenesis or hypogenesis. Moderate dilation of the lateral ventricles is observed. Cerebral parenchyma. The brain parenchyma demonstrates abnormal gyral patterns. Absence of the cavum septi pellucidi. Cerebellum and posterior fossa. The cerebellum appears hypoplastic. The cisterna magna is obliterated. Extracranial anatomy. Cardiac examination reveals a complex congenital heart defect. No additional structural anomalies noted at this time. This is the impression. Findings are suggestive of Semilobar Holoprosencephaly, characterized by incomplete forebrain division, particularly noted anteriorly with associated midline and posterior fossa abnormalities. Recommendations: urgent referral to a fetal medicine specialist for detailed assessment and management planning. Consider fetal MRI to further characterize brain morphology and associated anomalies. Genetic counseling to discuss the likelihood of chromosomal abnormalities or single gene disorders. Detailed fetal echocardiogram to assess the extent of the cardiac defect. Counseling regarding the significant neurological impairment and potential for life-limiting impact associated with this condition. Discussion of options, including continued intensive monitoring, potential interventions, and consideration of the broad spectrum of outcomes for Semilobar Holoprosencephaly. Note to referring physician: given the severity of the ultrasound findings, a multidisciplinary team approach including neonatology, pediatric neurology, and genetic counseling is recommended to provide the family with comprehensive care and support. Now we have a case of Lobar Holoprosencephaly. Clinical indications: referral for further assessment following an abnormal anatomy scan at 20 weeks suggesting possible forebrain abnormalities. No significant family history of genetic disorders. Gestational age 26 weeks. These are the findings. The BPD and HC are within normal limits. Cranial anatomy. Near complete division of the cerebral hemisphere is noted, with more fusion noted anteriorly. Incomplete separation of the deep gray matter structures with partial fusion of the thalami. The interhemispheric fissure is partially developed, more complete posteriorly. Rudimentary falx cerebri is present. Mild ventriculomegaly is noted. Cerebral parenchyma, simplified gyral pattern with absent or hypoplastic olfactory bulbs and tracts. Septum pellucidum is absent. Cerebellum and posterior fossa. The cerebellum and cisterna magna appear normal. Extracranial anatomy. No additional structural anomalies identified. Normal cardiac four-chamber view and outflow tracts. This is the impression. Findings suggestive of Lobar Holoprosencephaly, characterized by near complete but incomplete separation of the cerebral hemispheres, more evident anteriorly, and fusion of the thalami. There is a mild ventriculomegaly and a simplified gyral pattern. Recommendations: referral to a specialist in fetal medicine for comprehensive management and counseling. Fetal MRI recommended for detailed brain anatomy assessment. Genetic counseling for discussion regarding potential etiologies, including chromosomal abnormalities and genetic syndromes. Continuous follow-up and monitoring of the fetal brain development and ventriculomegaly. Postnatal neurological consultation to prepare for potential management of neurodevelopmental challenges. Note: the family was counseled regarding the findings, the nature of the condition, and the possible outcomes. Emphasis was placed on the need for multidisciplinary follow-up and support, including after birth. Further genetic testing and consultation with pediatric neurology were recommended. This is a report for Agenesis of Corpus Callosum. Clinical indications: referred for detailed fetal brain ultrasound due to abnormal findings on the routine 20-week anatomy scan. The patient has a non-contributory family history. Gestational age 23 weeks. These are the findings. The BPD and HC are normal. Corpus callosum. The corpus callosum is not visualized, suggesting agenesis. There is absence of the cavum septum pellucidum. Lateral ventricles. Mild ventriculomegaly is noted, with a teardrop shape characteristic of corpus callosum agenesis. Third ventricle elevated and dilated. Cerebellum normal in appearance. Cisterna magna and cerebral hemispheres are normal, and there are no additional structural anomalies identified in the scan at this time. And here is the impression. Ultrasound findings are suggestive of agenesis of the corpus callosum, characterized by the absence of the corpus callosum, mild ventriculomegaly, and a high-riding third ventricle. Recommendations: referral to a fetal medicine specialist for further assessment and detailed counseling. Consideration for a fetal MRI for more detailed visualization of the brain structures and to rule out associated anomalies. Genetic counseling should be offered due to the potential association of agenesis of the corpus callosum with genetic syndromes. Regular follow-up ultrasounds to monitor fetal growth and the progression of ventriculomegaly. Counseling regarding the potential neurodevelopmental outcomes, which can vary significantly in cases of corpus callosum agenesis. Note: the findings and their implications were discussed with the patient, emphasizing the importance of multidisciplinary care and follow-up. The patient was receptive to the recommendations and agreed to the scheduled consultations and follow-up scans. This is a report for Anencephaly. Clinical indications: abnormal finding noted during routine second trimester screening ultrasound. The patient has no significant medical or family history of congenital anomalies. Gestational age 18 weeks. These are the findings. BPD, unable to measure due to abnormal cranial structure. Head circumference significantly reduced. Cranial anatomy: there is an absence of the cranial vault above the level of the orbits, consistent with anencephaly. The cerebral hemispheres are not visualized. The base of the skull and facial structures, including the orbits, appear intact. There is evidence of rudimentary brain tissue, which is consistent with area cerebrovasculosa. Spine: the cervical spine is visualized and appears normal. The examination of the lower spine is unremarkable. Additional observations: normal amniotic fluid volume. The placenta, umbilical cord, and remaining fetal anatomy are otherwise normal in appearance. Here is the impression. Findings are consistent with anencephaly, characterized by the absence of the cranial vault and major portions of the brain. This is a lethal anomaly with no potential for survival postnatally. Note: the family was provided with preliminary findings and counseled about the nature and implications of the diagnosis. They were receptive to further consultation and expressed a desire for comprehensive support. This is a case of Acrania or Exencephaly. Clinical indications: routine first trimester ultrasound showed a possible cranial abnormality. The patient has no significant medical or family history of congenital anomalies. Gestational age 16 weeks. These are the findings. The femur length is normal. Cranial anatomy: the calvarial bones are absent. The brain tissue is visible without the normal covering skull bones, consistent with Acrania or Exencephaly. The cerebral hemispheres are present but exposed, without the protective covering of the skull and skull. The facial structures, including the orbits, appear normal. The base of the skull is intact. Spine and neck: the cervical spine is visualized and appears normal. No evidence of spinal defects in the visible portions of the spine. Additional observations: normal amniotic fluid volume. The placenta and umbilical cord are also normal. This is the impression. Findings are consistent with Acrania or Exencephaly, characterized by the absence of the cranial bones with intact cerebral hemispheres. This condition typically progresses to anencephaly as the pregnancy advances. Recommendation: immediate referral to a maternal fetal medicine specialist for confirmation of diagnosis and comprehensive counseling. Discussion with the parents regarding the prognosis, which is poor, as Acrania, Exencephaly is a lethal condition with no potential for survival postnatally. genetic counseling to discuss potential causes and recurrence risks in future pregnancies. If the pregnancy is continued, psychological counseling and multidisciplinary support should be offered to the parents. This is a report for Encephalocele. Clinical indications: abnormality suspected in the posterior cranial region on routine second trimester anomaly scan. No known family history of neural tube defects or genetic disorders. Gestational age 21 weeks. The biometric parameters are all within normal limits. Cranial anatomy: a defect in the occipital region of the skull is noted. A sac-like protrusion is observed extending from the cranial defect, consistent with an encephalocele. The sac appears to contain both meninges and brain tissue. No significant ventriculomegaly or other intracranial abnormalities are noted. The spine was normal and no other abnormalities were found. This is the impression. The findings are suggestive of an occipital encephalocele characterized by a defect in the occipital bone with herniation of brain tissue and meninges. Referral to a maternal fetal medicine specialist for further evaluation and management. Consideration for fetal MRI to better delineate the extent of the brain herniation and to assess for any additional anomalies. This is a report for Dandy-Walker malformation. These are the findings. The BPD and HC are normal. Cerebellum. The cerebellar vermis appears hypoplastic and upwardly rotated. Posterior fossa. Enlargement of the fourth ventricle with a cystic dilation is noted, characteristic of Dandy-Walker malformation. Cisterna magna, significantly enlarged, measuring more than 10 mm. Moderate ventriculomegaly is present, likely secondary to the Dandy-Walker malformation. No additional structural brain anomalies are identified in this study. The corpus callosum appears intact. No other gross structural anomalies are identified in the current scan. Normal amniotic fluid volume. This is the impression. Findings are consistent with Dandy-Walker malformation, characterized by hypoplasia and upward rotation of the cerebellar vermis, cystic dilation of the fourth ventricle, and enlargement of the posterior fossa. Consideration for fetal MRI for a detailed assessment of the brain anatomy and to evaluate for any additional anomalies. Serial ultrasounds to monitor fetal brain development and potential progression of ventriculomegaly are recommended. This is a report for vein of Galen malformation. Indication: routine prenatal screening, 28 weeks gestation. The cerebral hemispheres, cerebellum and choroid plexus are normal. The ventricle system is not dilated. A prominent vascular structure was identified in the midline of the fetal brain, consistent with a dilated median prosencephalic vein, suggestive of a vein of Galen aneurysmal malformation. The malformation appears as a large echogenic midline structure at the level of the thalami, with turbulent flow noted on Doppler ultrasound. There is no evidence of heart failure or hydrops fetalis at this time. Here is the impression. The findings are consistent with a vein of Galen malformation, a rare arteriovenous malformation of the cerebral vasculature. This anomaly can lead to significant morbidity due to high output cardiac failure and hydrocephalus. Close monitoring of fetal growth and cardiac function is recommended. along with referral to a pediatric neurosurgeon and neonatologist for postnatal management planning. Consideration for early delivery and the need for neonatal intensive care should be discussed. Recommendations: follow ultrasound in 2 weeks to monitor fetal growth and cardiac function. Fetal MRI may be considered for further characterization of the malformation. Consultation with a multidisciplinary team including maternal fetal medicine, neonatology, and pediatric neurosurgery. This is a report for intraventricular hemorrhage. Indication for study: abnormal findings noted during routine prenatal screening, 32 weeks gestation. These are the findings. The fetal brain anatomy was visualized. The cerebral hemispheres, cerebellum, and choroid plexus appear normal for gestational age. The ventricular system is visualized. Echogenic material within the lateral ventricles, more prominent in the left ventricle, suggestive of intraventricular hemorrhage. The lateral ventricles are mildly dilated, measuring 12 millimeters, indicating mild ventriculomegaly. There is no evidence of significant midline shift or compression of the surrounding brain tissue. Doppler ultrasound does not show abnormal blood flow patterns suggestive of vascular anomalies. Here is the impression. The sonographic features are suggestive of intraventricular hemorrhage. IVH in fetuses can be associated with developmental anomalies, infections, or maternal trauma. The mild ventriculomegaly warrants close monitoring for potential progression. Further evaluation and monitoring are essential to assess the progression and potential impact on fetal development. Follow-up ultrasound in 1 to 2 weeks to monitor ventricular size and assess for any progression of hemorrhage. Here is a report for CMV infection. Indication for study: suspected intrauterine infection, 29 weeks gestation. These are the findings. The fetal brain anatomy was visualized. There were several abnormalities noted which are concerning. The cerebral ventricles are borderline dilated, measuring approximately 10 millimeters, suggesting mild ventriculomegaly. Multiple echogenic areas within the periventricular region, consistent with periventricular calcifications. The cerebral cortex appears irregular and echogenic, which may indicate cortical dysplasia. There is evidence of mild cerebral atrophy with increased extraaxial fluid spaces. The cerebellum and posterior fossa structures appear unremarkable. This is the impression. The sonographic features are suggestive of congenital CMV infection. The findings of periventricular calcifications, ventriculomegaly, and cortical irregularities are typical of this diagnosis. CMV infection can lead to significant neurological impairment and developmental delays. There is a risk of associated complications such as hearing loss, vision impairment, and motor deficits. Confirmatory tests for CMV infection through amniocentesis and maternal serology is recommended. Follow-up ultrasound in 2 to 3 weeks to monitor the progression of brain abnormalities is advised. Consideration of fetal MRI for detailed assessment of brain anatomy and extent of damage. This is the report for Chiari 2 malformation. Indication: abnormal findings in routine prenatal screening, 24 weeks gestation. Here are the findings. The fetal brain anatomy was visualized with several notable abnormalities. The cerebral ventricles appear normal in size. The cerebellum demonstrates a banana sign, with the cerebellar hemispheres appearing elongated and curved around the brain stem. There is evidence of a lemon sign with scalloping of the frontal bones. The fourth ventricle and part of the cerebellum appear to be extending into the upper cervical spinal canal, suggestive of hindbrain herniation. No clear signs of associated neural tube defects, such as spina bifida, observed in the current plane of imaging. This is the impression. The sonographic features are consistent with Chiari 2 malformation. The classic banana and lemon signs are indicative of this diagnosis. Chiari 2 malformation is often associated with myelomeningeocele, a form of spina bifida, though not observed in this ultrasound. Further imaging might be required for comprehensive evaluation. This condition can lead to complications such as hydrocephalus and developmental delays. Follow-up ultrasound to further investigate the possibility of associated spinal anomalies. Consideration of fetal MRI for detailed assessment of the extent of hindbrain herniation and to rule out any additional anomalies. Thank you so much for watching. Please subscribe and stay tuned for more imaging videos.